Okay, so hello everybody, and welcome to these six models of the Maloclinic protocol regarding the Olin-4. So my name is Ana Ferro, and it is for me a pleasure to be here with you. So we'll start these two first models talking about the surgery regarding the Maloclinic protocol. Then we have two models that will be regarding the prosthodontic aspects of this protocol. And finally, we'll have two models that will be on the maintenance and how to keep this type of work for a long time. So first of all, thank you very much for the invitation. My name is Ana Ferro. I am the head of surgery at the Maloclinic in Lisbon, and I've been working with at the Maloclinic and performing the Olin-4 protocol for 15 years now. So as you might know, we have quite an experience in this subject, and we have been developing this concept for a long time now. So, as you know, this type of protocol is a protocol that was designed for rehabilitation of edentulous or soon-to-be edentulous patients. So when we start talking about edentulous patients, first of all, we have to talk about the importance of the total rehabilitation. And when we talk about the importance of the total rehabilitation, we have to talk about its numbers. And basically, when we look at the numbers of edentulism, we can see actually that the global population over 65 years is coming higher. Actually, it will double in the year 2025 from the levels that we had in 2005 to 820 million people. And in edentulism, in Europe itself, it is estimated to have about 40 to 50% of population over 65 years by the year 2050. I will be over 65. So this is very important because we're talking about a huge number of population to which we can address this type of treatment. When we look at the rates of edentulism, and we have these numbers that are from 2003 already, and we can see that actually the rate of edentulism is very high in many countries. When we go, for example, to Canada, we see that 58% of the population over 65 years is edentulous. When we go to the UK, for example, we talk about 46% of this population. So the numbers are very high, and people really, really need to be rehabilitated. So when we think about the edentulism, and in America, we can see that it's estimated just by next year around 38 million edentulous Americans. And when we talk about what they are rehabilitated with and what they're wearing, we can see that 90% of the edentulous patients, they address the problems that they have to their removable dentures. And why is that? Well, because we know that edentulism has a huge impact on our patients' lives. So the first questions that we have to ask ourselves is why? Why am I here? Why are you there? Why are you listening to me? And the answer is very, very simple. The answer is because of Maria, and it's because of José, and it's because of Manel, and it's because of all the patients that enter every day in my office, but also in your office, to which we have the possibility to help them. Because we know that edentulism has a huge impact on people's lives. When patients start to lose one tooth, that is a very early sign of aging, and nobody wants to get old. So we know that starting to use removable dentures, people are afraid to go out. They don't feel comfortable to go and eat in restaurants because they're always afraid that the denture will fall out. So it's very uncomfortable for them. It will actually have a big impact on their self-esteem, for example. So you can imagine, for example, that you would be someone that is wearing a removable denture and how it affects its psychosocial life, the quality of life, its nutritional condition. So if you can put yourself in that position and imagine yourself like being, for example, a politician, and you are in parliament and you are delivering the most important speech of your life. Now you are delivering your speech and you are trying hard not the danger to fall out of your mouth. So this is very complicated because now nobody's listening to him anymore. He's trying hard, and at the end he takes the danger out and puts in his pocket because this is what it's all about. So at the end, we can imagine that it has a huge impact on patients' lives. On the other hand, what happens is that basically you have a great power because if you are able to provide your patients with fixed teeth, you can actually give their functional capability in terms of static, comfort, speaking, but also restore their self-confidence, their nutritional condition, and improve your patient's quality of life. So, meanwhile, I just want to say that you can dig into the chat, and if you want to ask questions online while I'm talking, you are more than invited to do that because you don't need to be there just sitting and listen to me, but meanwhile, you can always text your questions, and I will try during my speech to basically to give back the answers. Okay? Great. So having said this, basically, I always want to share with you a clinical case, and it's a clinical case that actually changed my patients' lives and my life itself because it had a huge impact on my patients. So this is Guy, and Guy came to me 10 years ago. And 10 years ago, she looked like this. She was in her early 40s, and she had no teeth in the upper jaw, as you can see. She had just some crowns in the lower jaw. And basically, what we can see is that this patient was considered already an edentulous patient. So we have done the OPG, and we have done the CT scan, upper and lower CT scan, and we decided to go for All-on-4 upper and lower jaw. So in the same day, we got to give Guy a very nice fixed teeth back, and as you can see, these are the provisional prostheses that the patient has in the day of the surgery. So this is Guy with her prostheses, provisional prostheses, and here we can see the OPG already with the final prostheses. So here in Portugal we have a saying, and the saying is that a picture says more than 1,000 words. So let me just share with you Guy's pictures now on her Facebook. So this is how G looks now. Of course you can see it's the same person, and it's now, so 10 years after the surgery. And 10 years after the surgery, she actually looks 10 years younger than when she came. Because actually, this is what happens, is that actually it has the possibility of changing our patients' lives. So of course she painted her hair, she's not wearing glasses anymore, but she tells me, you know, I know having fixed teeth back was what gave me the boost to actually to believe in myself again, and to think that I was young and I still had a lot to live, because when I was very young, I started to lose teeth, and when I was in my 20s, I already was feeling very old. So this was one of the first cases, so to say, that made a huge impact to me, because you can actually see how it changed your patients' lives. Now we come to the question, what is the All-on-4? So probably you have an idea, you already know what is the All-on-4, but what do we consider to be the All-on-4? Well, the principles of the All-on-4 are actually that we use only 4 implants that are placed for a full arch reconstruction, that the angulation of the posterior implants are at a maximum of 45 degrees, The implants are anchored in bone, for example, or not, which means that when we talk about the maxilla and the mandible standard All-on-4, the implants are anchored in the bone. But when we talk about the zygoma implants, which we will talk next week, you will see that part of the implant is not anchored in the bone at all. So we'll use cantilever if needed in the final prosthesis. And we will deliver a bridge immediately after the surgery, so in the same day of the surgery. So we'll go for immediate function using a fixed all-acrylic bridge. And of course, as we know, we will reduce the bone if needed. So why do we do the All-on-4? Because we want to avoid more complex cases, more complex surgeries. We try to avoid bone grafting by using that. We have high success rates. It allows for a high hygiene maintenance capability, and it allows the patient to immediately have teeth. Now, the evolution of this protocol is very exciting, and it has been very exciting, and will continue to be very exciting, because the protocol that we use today is not exactly the same that we were using 10 years ago or 20 years ago. And more than 20 years ago, we had basically a desire of changing the rehabilitation. And to have this desire and to have an evolution of the concept, we always have several goals in mind. And the goals that we have for the total rehabilitation are the several. We want to have and to deliver a fixed bridge with high quality and aesthetics. We want to deliver it in the same day that we do the surgery, so we want to allow the patient immediately to have fixed teeth. We would like to avoid complex surgeries, so we want to do everything just in one surgery. We want to avoid bone grafting. You know, there are many people where you cannot actually propose to go for a hip transplant, people that have systemic disorders that are very, very old with osteoporosis. So we want to avoid bone grafting and other type of prosthesis other type of surgeries as much as possible. We want, of course, to have a protocol that has very high success rates. And of course, we want these success rates not only immediately, but we want them long term. So in order to have very high success rates long term, we need a high hygiene maintenance capability of our patients and of our implants. And of course, we would like to have a protocol that would benefit as much patients as possible. So we want it to be as lowest cost as possible for the patient, so that more patients can allow to have this type of treatment. So how is basically the evolution? So the evolution started many years ago, and many years ago we were doing still a lot of bone transplants and doing as many implants as possible. Then we started with the All-on-4 protocol in the mandible. After having designed and seeing that it was working in the mandible, we tried to go for the maxilla with exactly the same protocol. But still, with the All-on-4 standard, we were still grafting in some cases. So that's when we jumped into the zygoma. But even in zygoma, with the latest protocol that we had, with the Brainmark approach, with the Brainmark implants for the zygoma, we were still not completely happy with the type of rehabilitation that we were having. So there was development also in the type of the approach to the zygoma and the type of implants used. So actually, it all started in 1989 when Dr. Malo and the team started to go for immediate function, still in single cases and small bridges. So in these single cases and small bridges, we were able to avoid occlusion when we started to load our implants immediately. And but it worked. We started to see that it was possible actually to go for immediate function. And we started to think, okay, how can we go for immediate function also in totally dentaless patients? Because when you deliver immediate aesthetics to the patient, you will also deliver immediate occlusion. So how do we do this? So we started to identify and checking how many implants we would need, where we should place the implants, are we able to tilt the implants, how can we go? So it was very interesting. From 1993 till 1998, there was the evolution of the protocol in the mandible. So we started in the mandible because in the mandible, usually the bone is better quality in terms of being able to have a good stability of the implant. So at that time, we were placing 6 implants and going for loading. But many times, unfortunately, what happened was that we did not have the space enough to place all these 6 implants. And actually, the survival rate of these implants was not so good, because what was happening was that we did not have place for them to have a good healing between the placement of the implants. So we started to think, okay, we should place 4 implants in between the nerves and 2 very small implants in the back. And actually what happened was that the implants with the back, that almost majority of the time were sleeping implants, they actually had also a lower survival rate of these implants. So we would end up the majority of the times with the 4 implants in between the mantle nerves, the coming out of the nerves. So basically this was the development of the Olin 4 in the mandible. And from there on, we started to go on with our protocol, and we started to see that it was working, and we started to follow our patients. So the implants that we were using by this time were the machine surface implants from NobelBioCare, the MK implants, MK2 to MK3 to MK4 implants from NobelBioCare, and they were working fine. The majority of the cases in the mandible, we could have a good primary stability. Everything was okay. But then we wanted to have exactly the same type of protocol in the maxilla. So when we started to do our maxilla cases, we ended up with a very big challenge. And the challenge was that when we started to go into the bone of the maxilla and started to use the same implant, unfortunately, the majority of the cases, we did not get a good primary stability. So, unfortunately, this implant design was not good enough to get a good primary stability in soft bone. So what did we do? We knew that we had to to design a new type of implant. So we needed an implant that would allow for a good primary stability, which means that would allow for another preparation protocol, which means that we would drill less, okay, and the implant, by going in, would do the expansion of the bone. So this is why it is so important for the implant to have this type of apex. The apex that you see on the implant has to be a tapered apex, so that it can go in and expand the bone, allowing also for a bicortical anchorage. So we are allowed with this type of implant that is tapered, at least in the apex, to do another preparation and place the implant, and the implant will do a condensation of the bone. By doing that condensation, not only it does not spin, but actually it enhances its primary stability. And it's very important to understand that the good bone in the maxilla actually is on the crest and on the cortical of the nose. So we would need to engage in these 2 corticals. So this is why it is so important to have an implant that has threads all the way from the tip to the top, from the tip of the apex to the top of the head. So this was a big evolution from 1996 till 2001, when we developed this implant design. The Speedy, that actually when we were using still in prototype, it was called the osteotomy implant, but then it speeds the function, speeds the immediate function and the rehabilitation, so it came out as a Nobel Speedy. Nowadays we have a big range of implant size, from 7 millimeters till the 50 millimeters of the zygoma. So it's actually maybe one of the biggest range of implants that you have in the market, that actually would suit basically all the cases. We have these special implants of 20, 22 and 25 millimeters that actually are very useful for several cases where you have very, very soft bone. So this implant was completely designed and completely developed for immediate function cases. As you can see, if I did not have these special implants, for example, of the 22 millimeters, I would not be able to deliver immediate function to these patients. These patients are patients that have a lot of bone, but it's extreme soft bone. So in order to engage on the cortical of the bone and to come out in the area of the 6, I need very, very long implants. So this is basically what we have. Now, there was also an internal connection evolution. At the time the Nobel Speedy Replace came out, we also had an internal connection coming out, which was the Nobel Speedy Replace. So we had the Nobel Speedy Groovy, which was the external connection, and the Nobel Speedy Replace with internal connection. But unfortunately, by this time the internal connection was a tri-lobe connection, so it was not a good connection for tilting implants and for immediate function. As you can see also from the design of the implant, you can see that the hand of the implant does not have threads all the way, so it was not engaging completely on the cortical of the crest. And by that we could not get a very good stability of this implant. Nevertheless, also the tri-lobe connection was not good, because in the tilting implant, actually then we only had 3 positions of our abutments in order to actually compensate the angulation of the implant. So we were not using an internal connection for the All-on-4. After this, we had an evolution in terms of the connection in Nobel Biocare for the conical connection with the Nobel Active. But again, nevertheless, this type of implant was not the preferable one, because it did not have threads all the way in the head area, and it was not engaging on the cortical. So we continued to use only the external connection. But till some years ago, where the parallel CC came out, that has exactly the same design as the Nobel Speedy and goes with threads all the way to the top. So nowadays we have a new surface of the parallel CC with the TI Ultra that has been improved in order to allow for a better integration of the tissues. So nowadays our preferable implants to do the All-on-4 are the external connection with the Nobel Speedy and with the internal connection with the parallel CC TI Ultra. One of the biggest secrets for me of the All-on-4 is undoubtedly the multi-unit abutments. So the multi-unit abutments that are connecting in the day of the surgery, they are like our best implant keepers ever, because everything that you do after the implant placement, after you connect the abutments, everything you do in terms of prosthesis, in terms of impression, etc., will be at the abutment level. So this protects actually my implant. So you're going to see that through our protocol, what we do is after 10 days, when the patient comes, we remove the prosthesis to remove the suture. After 2 months comes again, we remove the prosthesis. After 4 months, the same. So everything is done at the abutment level. Okay, so you have to create like a weakest link in your rehabilitation, and the weakest link is above the multi-unit. Okay, it's the connection between the multi-unit and the prosthesis, and not the opposite. So please, if you go for the all-on-4, please do not go to the head of the implant, please. So always use multi-unit abutments. Now, the latest evolution on the multi-unit abutments is that actually the multi-unit abutments have also a surface that is treated, and this treated surface is the XIL surface. So we will see. Till now, all the cases that I have, they look very nice in terms of the integration of these tissues, but it's still young. It's still something very new, so we still have to see how the results will be in the future. So we can see from all the studies that we have produced, we have all over the years we have then adapted the all-on-4 to the guided surgery. Nowadays we are adapting it to the navigated surgery, which will also be very interesting. But after the all-on-4 standard, we also wanted to improve our zygoma technique. So when we were still having the brain mark technique for the zygoma, we were still using a lot of bone transplant in order to have onlays, so that the coming out of the prosthesis would be better. But after that, what we decided was, with an extramaxillary approach of this technique, we would be able actually to try to come more on the crest of the patient. So there was a development in that aspect. You can see this was one of the cases. You can see what I am talking about. And in order to have this external approach of the maxilla, we then also needed another design of our implants. So this is why there was a new design of the implants in terms of the 0 degree implant, and for that we also needed abutments with 45 and 60 degrees. We'll come again to the zygoma more in the next webinar, but I just wanted to follow all the evolution of the all-on-4, and the zygoma is part of the evolution of the all-on-4. Because nowadays with this type of implants, actually you can have a solution for all your cases. For common cases to moderate resorption, or to moderate to severe resorption, using also then the zygoma line. So now the question that is very important to you is, how do I do this? How do we go with the Malo Clinic protocol? How does it work? So the first thing that we have to ask ourselves is, in the Malo Clinic protocol, we have a first phase that is very important in terms of diagnosis. We need to understand what type of rehabilitation we are going to provide our patient with, what type of prosthesis. Because of the type of prosthesis, then we have to be aware of the transition zone, the lip support. We have to check the bone volume, bone density, and then after having all these diagnosed, then we go into the surgery. Then we have the provisional prosthesis, final rehabilitation, and of course the maintenance. So when we come to the diagnosis and the type of rehabilitation, when we talk about a total edentulous patient, we know that we can of course use removable denture, overdenture, bone grafting, parallel implants, and the all-on-4 solution. All of them have advantages and disadvantages. When we talk about a removable denture, we know that the biggest advantage, of course, is the cost, but then it has a big disadvantage in terms of it's removable, it has lack of stability, it has poor function, and it's very uncomfort for the patient. In terms of the overdenture, Unfortunately, it's still a removable one. Of course, in terms of advantage, it still has an advantage of being in terms of costs, cheaper and of simple execution, but it has a non-efficient cost-benefit relationship. So, and it will require a high maintenance. When we talk about bone grafting, of course, this is a possibility when you don't have a lot of place to place the implants, when it's impossible to place the implants. So you create with the bone grafting a possibility of placing standard implants in the maxilla. Nowadays, with the double zygoma technique or the quad zygoma technique, basically we can avoid this type of surgery because it has a lot of disadvantage in terms of costs, success rates. You don't know exactly how much bone it will be resorbed. It's discomfort for the patient. It's a very high period remaining without teeth. We have, for example, the study that was published this year from Ruben, my good friend Ruben Davo, and from Exposito. And what happened was they compared the use of bone grafting. They did a multi-center study, one center in Italy that was performing the bone grafting for rehabilitating edentulous patients, and the other in Alicante, where Ruben placed a double zygoma in cases that we had no maxilla at all. So what the conclusion of the study was actually that in terms of patients having fixed teeth again, it was 1.2 days in a quad zygoma compared with about 412 days, something like that, when patients were subjected to a bone grafting from the hip. So it's quite a big difference in terms of patients' comfort and patients' ability to have fixed teeth again. So, like this, I think that it's a solution that will only be for me a solution when you cannot place the zygoma. In terms of parallel implants or several implants in the maxilla, of course, sometimes it's not possible if you don't have available bone. It will lead to higher costs, and well, basically, it will come to a more difficulty case in terms of having a good passive fit of your prosthesis. But you can have a segmentation of the bridges. But if you have, for example, false gingiva in these bridges, you won't have a very good aesthetics. Comes to the Olin-4. In the Olin-4, it has a lot of advantage, meaning that it will allow for a fixed restoration with higher aesthetics. It will allow for immediate function. It has very high success rates, eliminates bone grafting, and it's actually a very simple surgical protocol and also prosthetic protocol and maintenance protocol. But the disadvantage, unfortunately, we have been doing this for more than 20 years. It's still a new concept that requires acceptance. So when we talk about this concept that requires acceptance, many people talk about, about the tilting of the implants. This is something, is it working, not working? This is something new. It's not new. And in terms of biomechanics, how it will handle, well, basically it's like this. We have in the literature many publications, clinical publications with the use of tilting implants with a two-stage approach or immediate function that we published in 2003 already. And the first publish was from Krekmanov in 2000 with the use of the tilting implants. And Krekmanov stated that by tilting the implant support actually is moved posteriorly, and the implant length can then be increased by it. And by increasing the length, then the implant will actually follow dense bone structures, enhancing like this its primary stability. So in his study of 5 years, the cumulative success rate was that the tilted implants in the maxilla and in the maxilla and in the mandible had very high success rates, survival rates. Actually, in the maxilla, the tilted implants had even better success rate than the actual ones in the maxilla. So in his procedure was a 2-stage procedure with 206 implants. So his conclusions were that the implant tilting per se does not induce any biologic disadvantage, and biomechanically the position of the coronal end of the implant is actually more important than whether the implant is tilted or not. When we go for the review of Peñarrocha and the meta-analysis from Krkonovic, we can actually see that the conclusions from both of these very important publications are actually very interesting, because in the review from Peñarrocha, he got together 13 studies. With 782 of the implants placed were tilted, with high success rates, as you can see, from 91.3% to 100%, with bone loss from 0.4 millimeters to 0.92. And with the actual ones, 666 actual implants, with also very high survival rates, and with bone loss of 0.35 to 1.21. So you can see also from the publication or the meta-analysis from Krkonovic in 2015 that he got together 44 publications, and from his meta-analysis, as you can see, from the tilted implants he had 1.63% of the implants that failed and 1.81% of the actual implants that failed. So the tilting does not affect the survival rate or the bone loss. So we can see that the tilting of implants lead to high success rates, minimal complications, and very high patient satisfaction when we compare to the actually traditional protocols of doing sinus lift and bone grafting, etc. So in terms of biomechanics, why are we tilting the implants? Well, basically, why are tilting the implants? This is not something new. This is something that we can see every day. Wherever we look, we can see it every day. And basically, we know that the tilting of the implants is actually very, very beneficial for our bridges. So we can see that here in terms of biomechanics, I bring you with 2 studies, and these studies are one from Zampelis and another one from Bevilacqua. So in the study from Zampelis, he did basically a study using a framework that was connected in 2 implants. So he wanted to see the effect that the implants had on and the forces that were produced. When the forces were produced on the last implant, the impact that it had on the stress produced around the last implant. So we can see that being the implant straight or being the implant tilted, if we do just the same force on the structure, then the stress that will be felt around the implant will be actually the same. Now, when we increase the cantilever, when we increase it and we do the force on the cantilever, what happens is that it doesn't matter if the implant is straight or tilted, it will actually increase the stress around our implant. And it will be actually the same. Now, when we think, does it matter if the implant is a longer implant or a shorter implant? Will it affect the stress that is produced around the implant? And actually not. So the implant itself, being it bigger or smaller, does not affect the stress that is produced around it. Okay? So when people ask me, do you use short implants for the All-on-4? Yes, I use short implants for the All-on-4 here, especially in the front, when we don't have a lot of bone, when we have about 6-7 millimeters of bone in the anterior region. So we use that short implants. Now, when we compare, what is very nice to compare from here is that if we have the nerve coming, imagine that we have the nerve coming out there, and if we, by tilting our implant, are able to diminish the cantilever, then it is very beneficial because it will reduce actually the stress around my implant head. So the distal tilting of implants in splinted fixed restoration does not increase the bone stress, and the stress of the bone is lower when we use tilted implants instead of cantilevers. Now, another very interesting study from Bevilacqua. He did the same type of study, and he actually wanted to see the influence that it had not only on the tilted implant, but on the axial and on the metal framework. So by starting to have one implant straight, tilting it with 15 degree, 30 degree, or 45 degree, and by having this angulation, it would also reduce the cantilever. So we can see that by reducing the cantilever, having a bigger angulation, we are going to reduce also the force that it's felt around the tilted implant, the axial implant, and on the metal framework, as you can see it here. So the tilted distal implants rigidly splinted with a fixed prosthesis decrease the stress in the peri-implant bone and frameworks. Now another question is, why do we use Fourier implants? We're not the first one to use Fourier implants. Bradmark itself was using Fourier implants already, but by the time he was not immediately loading it. But this study from Nakanishi is very interesting because we can see with the use of 5 or 4 implants, and when the forces are produced in the cantilever, we can actually see how the rest of the force are going to behave in the other implants. And we can see that, for example, the direction of the force is felt more on the first 2 implants, being it in the same direction, the first one, being it in the opposite direction. So you can see that when we have the cantilever and we have straight implants, we will feel about 2.8 times of the initial force, as you can see here. Now, one thing very important that we can realize is that the implant in the middle, when you compare 5 to 4 implants, does not actually play any role at all. So it might be actually better in terms of biomechanics and, of course, in terms also of cost to only have 4 implants. Now, how will they behave if we start to tilt our implants? Well, actually, in this type of study where he had 5 implants or 4 implants and they were tilted, here you can see much better that by tilting the implant, the posterior implants, the one in the middle, when we are talking about the 5 implants, actually does not play any role at all. It only alleviates about 6 Newton force in terms of upforce. So when we compare not using tilted or non-tilted, we can see here that we are actually, by tilting just the implants, we can reduce the forces that are felt around our implants and around our framework. So at the end, we can see that if we can use a tilting implant and by that avoiding as much as possible the type of cantilever that will feel, well, actually it will be very beneficial. So coming to the type of rehabilitation, we have to understand that this type of surgery that we are going to perform is completely guided by our prosthesis. So we need to know actually what type of prosthesis are we going to provide our patient with. And the principles of the Malaclinic bridge is that there is always a one-piece bridge. It can be full acrylic, or metal ceramic. It will always have false papilla and soft tissue, false soft tissue, as you can see, the big gingiva. It will use cantilever if needed, and it will allow for immediate functioning with an all-acrylic bridge. We will need bone reduction if necessary in several cases, as I'm going to show you. So it will allow the patient to have a high aesthetics. It has a high mechanical resistance with the metal framework, has high hygiene maintenance capability, it allows to be repaired with high quality and fast, and has low cost for the patient with a full acrylic bridge. Now, as you can see up, this is the traditional protocol, where patients are rehabilitated using their own gingiva and using a metal ceramic bridge. And in opposite, we can see this is the Malaclinic protocol, where we rehabilitate our patients with bridges that have teeth and artificial gingiva. Now, why do we do this? Well, when we have this type of rehabilitation, we have to be aware of many things like the transition zone. What is the transition zone? Transition zone is the zone of transition between the artificial gingiva of the patient and the natural gingiva of the patient. Now, why is it so important? Because the smile line of the patient, the lip support of the patient, and the prosthetic space that we will need to do our prosthesis will tell me, in terms of surgery, if I will need to do bone reduction. So we can have a high smile line, and if I have a high smile line, it's because the patient is showing the gum when smiling, or a low smile line when the patient does not show the gum when smiling. So if I have a high smile line, basically I have two possibilities of rehabilitation. Or either I go with the traditional protocol using metal ceramic prosthesis with the natural gingiva of the patient, or I go for a Malaclinic bridge with false gingiva of the patient. So, if I go with the metal ceramic approach, I of course do not need any bone reduction, but it's difficult to achieve a good long-term aesthetic outcome. And it's a very demanding surgical technique because I have to place my implant exactly where the teeth are coming out. I am not able to choose where I have the best bone available to place my implant. I cannot place an implant exactly in the papilla. And many times it is between the central and the lateral that I have the best bone available. Another thing that it's important is that you have to understand. Of course, there are many people that can do a beautiful contour of the soft tissue of the patient. And maybe they can do it for a long time. But it's very difficult. You start to have soft tissue papilla because you have bone papilla. But once you have extracted all the teeth, the bone doesn't look like this anymore, the bone looks like this. So it's very hard to achieve good long papilla and for this papilla to last forever. So, because of that, and creating the protocol that goes for everyone, of course we can go for a type of protocol where we decided actually to go for a prosthesis with acrylic gingiva. So, as you can see, this is possible. Of course it's possible. But in terms of long term, in terms of aesthetics, in terms of patient comfort, we think that it's better to go with the other type of prosthesis. But on the other hand, if I go with a false gingiva, I cannot see the transition zone between the natural and the false gingiva, because that would kill aesthetics completely. So, what do I have to do? Well, if I have a patient with a high smile line, I have to reduce the bone. So by reducing the bone, I will place my implant higher, and when the patient smiles, we do not see the transition zone between the artificial and the natural gingiva of our patient. So when we compare one to the other, of course, we prefer to go with the monoclinic protocol. So when we don't have a high smile line, we always go, we don't have to think about that, we won't have the transition zones showed, so we always go for prosthesis with false gingiva, with no bone reduction needed because of this. Another thing that it's important still in the diagnosis is to check on the lip support. What happens is that when the patients start to lose teeth, well, basically they will have bone resorption. They will start to have bone resorption, and with the bone resorption, what happens is that you start to lack the lip support. Now, in order to have a good lip support, again, what can you do? We are not going to use overdenture, we are not going to have a flange in our prosthesis. So I can, of course, cut my maxilla and put dual deform, for example, put the maxilla to the front. I can do one leg grafting, for example, but we are only going to use the monoclinic bridge. Now, what do we need to be aware? Well, basically, as you know, our prosthesis will end up when the acrylic gingiva of our patient, when the natural gingiva of our patient will start. So, we have to be aware of the angulation that we will have between the artificial gingiva and the natural gingiva of the patient. So this angulation should be less than 45 degrees, so that when the patient smiles, when the patient eats, when the patient does everything, the lip can go up and down very gently. So, but unfortunately what happens is when we have severe lack of the lip support, we want our teeth to be there in order to give a good lip support. But then what happens is that this angulation is bigger than 45 degrees. So the patient comes to the clinic like this. And you think that the patient is very happy because he's always smiling, and you ask the patient, "Are you happy?" "No, doctor, it's because it's very hard to take my lip from that part. It's always stuck there. So it's very hard for the patient to smile, it's hard for the patient to have a good oral hygiene, it's very uncomfortable." So this angulation between the natural gingiva and the artificial gingiva of the patient should be less than 45 degrees. So what is the solution? Yes, again, bone reduction. So by reducing the bone, what happens is that the teeth will stay exactly in the same position, but the implant will get higher, and now the angulation goes like this, diminishing. Of course, the prosthesis gets longer, but now the angulation is less than 45 degrees, and the lip can go up and down very smoothly. Now, coming to the last part of our diagnosis, in terms of bone volume and density. What is our protocol? Well, basically from full bone volume to no bone at all. If we have a lot of bone, meaning if we have a full bone volume in the area of the first molar, of course we can place 6 straight implants. I'm checking if you have any questions. No questions? Come on. Please feel free. So, if we have a lot of bone, we can actually place 6 straight implants parallel to each other, first molar, first premolar, and lateral. So, this is an easy going, so to say, but unfortunately, it's very rare. It's very rare to have this amount of bone, okay, and this amount of bone to be of good bone quality, which would lead to a good primary stability. So with the bone, with the losing of the teeth, and with the pneumatization of the sinus, and with usually very soft bone in the back, we will end up by starting to tilt our implant and entering the all-on-4 protocol. So we start by tilting our implant so that the implant will come out in the area of the first molar and the anterior implant more or less in the area of the canine. So these are our all-on-4 standard. So till where does our all-on-4 standard go? Well, by the time the sinus gets more pneumatized, we'll start to go with the tilting and straight implant more to the front, more to the mesial. So this is when it comes out in the area of the second premolar. If it comes out in the area of the second premolar, the posterior implant, in the end or in the final solution, the prosthesis will have to have teeth. But in the provisional, the patient will leave the clinic with only 10 teeth. So we do not deliver the olecolic bridge with cantilever. Okay? Now, the limit of our all-on-4 standard protocol is when the posterior implant comes out in the area of the first premolar. So that in the future, in the final prosthesis, it has 2 teeth in cantilever. So this is our limit. And this is our limit in the all-on-4 standard. Why? Because then, after this, when we lack the bone in the back, what we do? Well, basically, we start to go for the zygoma. So when we do not have any bone in the back, which means that we only have bone here in the front, from lateral to lateral, we start using our zygomatic implants, which are basically what we call the all-on-4 hybrid. Now, in terms of diagnosis, when we do not have any bone at all, like in these cases, we go for the quiet zygoma or the all-on-4 double zygoma, which is 2 zygoma implants on each side. So for us, a standard case, a good case is when we have 10 millimeters of bone available with 5 millimeters of width in the areas of the first of the canine. From canine to canine, if we have 10 millimeters of bone height with 5 millimeters of width, it's a standard good case. So today we are using this type of rehabilitation for the maxilla, 6 implants, all-on-4 standard, all-on-4 hybrid, or all-on-4 double zygoma. In the bendable is exactly the same, which means that if we have full bone volume, we have more than 10 millimeters in the area of the 6 of the first molar. Of course, we can go 6 straight implants, no problem at all. But usually we lack this type of bone, and usually we go for the all-on-4 concept. For us, a good case when we have like these 5 millimeters of bone height, of bone width with 10 millimeters of bone height in between the canine to canine, or in between the coming out of the nerves, which is our limit in the lower jaw. So now comes to the interesting part for you, I think, which is going into the surgery. So we have already our patient, we have gone through all this diagnosis, and now the patient goes into the surgery. So we go into the surgery, we will meet our lovely patient, we will start by looking at our patient, looking at the smile line. This is our OPG of our patient, and we always start in the same protocol. So we start by removing the teeth, doing an incision along the crest, as you can see, and 2 release incisions in the area of the first molars. Then we start releasing a full thickness flap, and we have to raise our flap till we see our limits. So we'll raise the flap till the nose and to the anterior wall of the sinus. Then we are going to reduce the bone, or because of the smile line, or because of the lip support, or because of the prosthetic height. We want to have at least 15 millimeters for our prosthesis, okay, 10 millimeters for the teeth, 3 millimeters for the bar, for the titanium, and 2 millimeters for the acrylic wraparound. After that, We place our GPS in the middle. Then we have to see exactly where we have the interior wall of the sinus. So we do a hole into the sinus, and then we see with the 45 degrees where we can start. We start our drilling protocol using the 2mm drill. 2mm drill is the most important drill. It will tell me the density of the bone, and it will tell me the length of my implant. So after this, I will drill with the 428, 3236, and here a little bit in the beginning with the 3842, because I'm going to use a 4.3 parallel CC implant with 13 millimeters. So I start to place my implant with 30 Newton torque. After this, stopped with 50, and now I check where I can have the position of my abutment. I connect my abutment, a 30-degree 4.3mm abutment, and now I do the same on the other side. Okay, so I start to connect my implant. After connecting my implant, I use my abutment to compensate the angulation, and because the bone is very thin, especially on the left side of the patient, we are going to use now 375 diameter implants in the front. So we go with the 2428 drill, and we connect our implant, 375 10mm implant. So we go just a little bit by hand, a little bit over 50. Don't over torque neither your implant. If you see that it's still a long way to go, take the implant out and drill more. So we always go for the posterior ones first, posterior implants first. After having the posterior ones done, we go for the anterior implants. So as you can see here, after this we suture everything. So these are the TI Ultra implants that I was telling you about, and these abutments are the axilla abutments. So now we do an impression. For the impression we use only putty silicone. We want to have the best security impression as possible, so we do a connection between our abutments or our impression copings, and do impression using only putty silicone, as you can see here. So after this we place these healing caps. These healing caps are for the gum not to swallow over the abutments. This is already the final immediate all acrylic prosthesis in the day of the surgery that is connected. We connect the prosthesis, and now we check for the occlusion. We want to keep the occlusion more in between the canines, and then we close the holes, the excess holes, with our catheter. So this is how it looks, our patient in the day of the surgery. So the most important thing is, first of all, clinical examination, radiographic examination. Always do CT scan of our patient, check the smile line, check the lip support, check the evaluation of the prosthetic space of your patient. Here, as you can see, this is the upper and the lower arch, intraoral pictures. Then we start our surgery. We start by extracting the teeth. We do an incision along the crest to release incisions in the area of the first molars. Then we clean all the alveolus. We raise a flap. We raise a flap till we see the limitations. The limits in the upper jaw are the interior wall of the sinus and the nose of our patient. After this, we are going to do bone regularization in terms of the smile and the lip support, prosthetic space. If it's irregular crest, we want everything at the same height. And after this, we have to place our GPS, which is this All-on-4 guide. So we go into the middle line, we do an osteotomy using the 2mm drill, and we place the pin. If the pin guide is perpendicular to the bipupillar line, after this we place our All-on-4 guide, which is a guide that you can adapt to. It's a universal guide, you can adapt to all kinds of mandibles or maxillas. Then you do a small hole into the sinus, you check and you probe where you have the interior wall of the sinus, and then with the 45-degree angulation we can see where we can start. So we start our drilling, we start with the 2mm drilling. After this, knowing what type of bone do we have, we drill more or we drill less. So this is what's called the under preparation protocol. Because when our implant is going to go in, it will push the bone and enhancing the primary stability. So this is what I'm talking about. We will drill according to the type of bone that we have. If I have a soft bone, in order to place an implant of 4.3, these are the drills that we are going to use. So if I have a soft bone, I only use the 2mm drill till the end and the other drills in the beginning. If I have a medium bone, I use the 2, the 2.4, 2.8 and the others just on the cortical of the crest. If I have a hard bone, I use all the 3 drills. And sometimes, even if I have very hard bone, I can even use, this is to place a 4.3mm diameter implant, I can even use the 3.8, 4.2 drill, okay? Now, sometimes for the mandible, I use all these if I have very hard bone, and sometimes for the maxilla, it's not enough to have to drill only with 2mm to the end. If I have very soft bone, I have to go and engage on the cortical of the nose, doing what we call the bicortical anchorage. So we have to understand what we are capable of and what we have in our possibilities in order to enhance the primary stability of the implants and in order to be able to load these implants and give our patients a proper immediate prosthesis. So after having placed our implant, we are going to place the abutment. We engage the abutment, and before this we use the bone mill. The bone mill is a type of trephine that we use to trim the bone around our implant head. So we trephine this bone around our implant head and then we connect our abutment, which is a 30-degree abutment with 4.5, in this case with 4.5mm height. On the other hand, we do on the other side another implant, and then we go to the implants in the front. How do we go to the implants in the front? Well, basically, we have to see exactly where the tip of our implant, the apex of our posterior implant is, and then we are going to choose where we have the best bone from that part to the middle line. And then we choose where we have the best bone available, and we drill, using again the same thinking. What type of bone do I have here? I have soft, medium, hard, drill less, drill more, okay? In order to get a good primary stability. After having connected all the abutments, we go for the suture, single suture, and we go for the impression. So we do the impression using, for example, Duralay. We connect with Duralay all the impression couplings with wire, but you can use acrylic, photopolymerized acrylic, autopolymerized acrylic, you can use compass, whatever you want. And then we go for the impression using only putty silicone. Now, sometimes we have the prosthesis prepared before. We will capture the cylinders, the interior cylinders from the mouth of the patient to the prosthesis that we have prepared before, and then we send to the lab to finish everything. But Philippe will talk about the prosthesis in 2 sessions. So this is how it looks in the end of the surgery. As you can see here, the implants are coming out in the second premolars. So we deliver the bridge with only 10 teeth. And this is how the tissues look in the day of removing the suture. Now, going into the mandible, I hope you're still awake. I was hoping for some questions, but no problem. No question at all. Okay, so I will just continue. And now we are going to talk a little bit about the mandible. So, when we go into the mandible, and you will see that the protocol is very more or less... hello, everything is more or less okay, it's more or less the same. So, we start by seeing this surgery. So, we had this patient that had some periodontal disease, had some mobility of the teeth, and did not have a good occlusion. So in this case, this was the treatment plan that was chosen for the patient, with the patient, to extract the teeth and to go for an all-on-4. So it's the same thing. We start to extracting all the teeth. We start to extract all the teeth, the remaining teeth. We are going to expose our limits. So the limits in the lower jaw are the coming out of the nerves. So we want to check exactly where the nerves are coming out. And after this, what do? Well, we start by cleaning all the alveolus, and we are going to do again a regularization of the bone. So we trim the bone. We start by reducing the bone because of the smile line, lip support, sometimes because just the crest is irregular, and we use the rounder, and we can also use this drill. If you use this drill, do not forget to protect the tissues. Now you can see it's very thin ridge in the beginning, so we are going to try to see where we can have the benefit from using the best bone available that we have. So we place our pin is in the middle line, and then we go and place our all-on-4 guide. So when we place our all-on-4 guide, then we check where the nerve is coming out, and we check also the loop of the nerve. So we have to probe the loop of the nerve to check where it's coming out, and then with the 45 degrees, check where you can start to drill your implant. So you check also if you have soft, medium, hard bone, and then you drill less or more according to that. In this case, we are going to use a Nobel Speedy Groovy implant, 4 by 13 millimeter, and we start to place it with 30 Newton, then with 50, and then when it locks with 50, we can go just a little bit by hand. The same thing, we use the bone mill to trim the bone around our implant head, and now we are going to connect 30 degree 4 millimeter abutment. Again, here you can see where our nerve is coming out, and we can see that we are going to start to tilt our implant with the 45 degree. We start our 2 millimeter drill. With the 2 millimeter drill, we check the type of bone that we have. We are drilling here more or less till 13 millimeters, and we are going to place also an implant of 4 by 13. So it blocked with 50, just a little bit by hand, again the bone mill, so you can see it's always the same protocol. After having placed the ones in the back, then we go to the ones in the front. So, one of the questions is how long lasts the whole duration of the treatment. So, thank you, Constantine, for your question. So, usually the surgery itself takes about 1 hour and a half, it depends. But in terms of delivering the prosthesis, we usually try to count with the whole day. So if we have a prosthesis prepared before the surgery, which we actually try to have it, So I would say that more or less at lunchtime the patient is already ready to go, which means that the patient is already with the prosthesis. Now, sometimes we have the need to do, for example, try-ins with our patient, try-ins of the prosthesis. And if we have the need to do try-ins of the prosthesis, then we might need to be the whole day. So this is usually a day that we say to the patient to take for us, that the patient should not schedule anything, so should be comfortable and relaxed and take the whole day. If the patient goes out earlier, better. If goes out just like, imagine at 6 o'clock or 8 o'clock in the evening, no problem, okay? So the important for us is to do everything well and to be able to deliver in the same day the prosthesis to our patient. I hope that answered your question. So again, as you can see, we connect all the abutments. The abutments are connected. For the impression, it's very important to have a very good impression in order to have a proper seating of the prosthesis, so that you have a good passive fit of your prosthesis. So, reviewing again from step by step, in this case a patient with an edentulous patient in the lower jaw, you can see we have thin keratinized tissue. What we do is we divide the keratinized tissue into two. We expose the bridge, we make a full thickness flap. Sometimes when we do not have a good flexibility of the tissues, you can do a release incision exactly in the middle. And we expose the nerves. So also in the lower jaw, we sometimes have to trim the bone. We will reduce the bone, for example, here, because the crest was very thin in the beginning, in order to have a proper crest for the seating of our implants. Then we check where the nerves are coming out, and we probe the loop of the nerve, so that when we probe the loop, we can then see with the 45 degrees where we can start. So we probe the loop, then we go 2 millimeters in the front, then we see, okay, with the 2 millimeters, angulation 45, where I can start in the crest. And this is where I start to drill. Before we start to drill, we have to connect, do not forget, in the middle line, I have to place our GPS. So we do a drilling with the 2 millimeter of about 10 millimeter, and we place our pin. If the pin is in the midline, everything is okay, then we place our Allen-Furth guide, okay? After this, then we will start our drilling in the posterior area. So again, 2 millimeter, 2.4, 2.8, 3.2, 3.6, it will depend on the type of bone that you'll have. And yes, in the mandible you can have also very soft bone. So we start our drilling, we drill, everything is perfect, set, and we place our implant. So we start to place our implant with a 30 Newton torque, and then we connect our abutment. Before we connect the abutment, we use the bone mill, so that we do not have any bone in between my abutment and the head of the implant. After having placed the posterior implants, then we go to the ones in the front. To place the ones in the front, we can use just this pin guide, and again we check where the tip of our implant is, where the middle line is, and we can use from this side to this, we can choose the best bone that we have to place our implant. So we place our implant, and after that we connect our abutments. After having connected all the abutments, impression cuppings, connecting impression cuppings, and do the impression with putty silicone. And at the end of the day, we'll deliver a fixed prosthesis to our patient. These are the healing caps that the patient that we put on the top of the abutments in order for the soft tissues not to swallow over the abutments. And this is how it looks in the mouth of the patient. This is the OPG with immediate bridges, and this is with the final prosthesis. Here you can see this is the OPG with 2 years of follow-up, and here the periapical X-rays with 2 years of follow-up. Here an OPG with the 5 years of follow-up. So now we go a little bit into the scientific support of the All-on-4 concept. And basically, I want to show you these were the data that we had till last year. Till last year, these were the data that there were 34 studies that were published with the All-on-4 concept using Novacare implants. And we had a short-term follow-up that had survival rates from 97.6% to 100%, mid-term follow-up from 96.9% to 100%, mid-term follow-up with 3 to 5 years of follow-up with 98.4% to 99.7%, and long-term follow-up from 5 to 10 years with 94.5% to 98.1%. So more than 2,600 patients were treated with more than 10,400 implants placed. So this year we published 2 very special studies. This one was the All-on-4 in the maxilla with up to 13 years of follow-up that we published this year at the Clinical Implant Dentistry and Related Research. So you can see for this publication we got 1,072 patients. For these 1,072 patients were treated here in the Malo Clinic Lisbon with 4,288 implants that were placed. We can see from the rates, the cumulative success rates regarding the implants that we had at 5 years, 97.7%, at 10 years, 95.6%, and 13 years, 93.9%. With the marginal bone loss at 5 years of 1.18 millimeters, 10 years 1.67 millimeters, and with the prosthetic success rate of 99.2%. So this was one of the cases that was involved in this publication. This patient that only had these 3 teeth in the upper jaw and has this bridge in the lower jaw, where we decided to go for All-on-4 upper and lower. These are the prostheses after the day of the surgery that was performed in 2005. And these are the final rehabilitations, upper and lower. Malo Clinic Bridge Ceramic 2006, Malo Clinic Bridge Acrylic 2006. Let me just... Okay, so one of the questions that someone is asking is how do you clinically mark the interior wall of the sinus during the surgery? So what do we do is actually, I did not know if you had the chance to check it, to see it, but what we do is that when we raise the flap, we open everything till we see the interior wall of the sinus, till we see the nose. So then we do a hole into the sinus, you do a small hole. When you do a hole into the sinus, you check with the perioprobe where the sinus is, okay? Then you can know exactly where the sinus is. If you want to mark it, you can mark. You can mark where the interior wall of the sinus is directly in the bone. You can use an orthopedic pencil and you mark it, okay? So that then with the angulation of the 45 degrees, you can actually see where you can start, okay? So this is what we do. you check it, and then you start the drilling with 45, and you see where you can start. So if you need it, you mark it with an orthopedic pencil, okay? And the minimum of the torque that I would advise you to go for repeated loading would be to go with the 30 Newton of torque, okay? This is the minimum that I advise you to go. Although we have to understand that when we talk about the total rehabilitation, when we talk about All-in-4, the rules that go for a coarse arch stabilization are completely different than the rules that we have for single or partial cases, okay? But I advise you to at least try to achieve a 30 Newton torque of your implant. So between 30 and 50, you can then go ahead and load it. So continue with this case. This is with the 5 years of follow-up, and here you can see with the 12 years of follow-up. So you can see that in the mandible we also have published in the mandible. When we talk before coming to this publication, one of the question is if we can go over 50 Newton or torque, if that would be okay. Well, yes and no, which means that if you, I know that you can get 70 or 80 newtons of torque with other types of machines, and other type of implants. But the thing is that when the first thing is that you don't need. So between 30 and 50 is more than enough, okay? And when you start to go with the big torques, first of all, you can start to damage the pieces that you are using. You can damage the head of the implant, you can damage the implant connection, you can damage the implant mount, you can damage all these tools. So don't over torque, because you also don't want to compress too much the bone, especially on the cortical. If you compress too much, then you can start to have some early bone loss just because of that. So my advice to you is actually to go with between 30 and 50 Newton torque. Good. So I will continue. Okay, I will continue. And what happens is when you start to place your implant, and when you start to drill, and if you are blocked with 30 Newton with a long way of the implant to go in, you take the implant out and you drill a little bit more. Okay, you drill a little bit more and then you connect your implant. Okay, don't go too much out and in, out and in, out and in, because this can also damage the mechanics of the resistance of your implant, and especially the connection, which sometimes it can be more fragile, especially when we are talking about narrow implants, internal connection implants. So don't overcharge it. Now we will continue. And about the vertical dimension and all this prosthetic, I will leave this to Philippe. Okay, Philippe will talk about the prosthesis and about how do we evaluate the vertical dimension. But actually what we have is what we take into consideration, the vertical dimension that we had of the patient before the surgery, and we decide if we would want to increase, to maintain, or diminish. Okay, so with this, imagine that the patient still has teeth, and we want to maintain the same vertical dimension. We do, during the surgery, at the beginning we do one mark on the nose, one mark on the chin, and we'll control this measure during the day with exactly the vertical dimension that we want. Okay? Good. So Coming to the long-term follow-up of 18 years of the All-on-4 in the mandible, we got together 471 patients with 1,884 implants that was placed. So at 10 years we got a cumulative success rate of 95.9%, 13 years of 93.5%, and 18 years of 91.7%. When it comes to marginal bone loss, we have at 10 years 1.72 and at 15 years 2.32 millimeters, with a prosthetic success rate of 98.8%. So this is one of the cases that was performed in 2002. We extracted all teeth. Here we can see we have used, by this time, still the MK implants. And here we can see the Maloclinic bridge, ceramic bridge in 2003. Here you can see the final OPG. And here, with 15 years of follow-up, the periapical X-rays. So now during the surgery, when we have perforation or when we have a deficiency of our implants, what do? We don't do anything. We don't do any GBR, we don't do any bone grafting, we don't do anything. We just let the implants, we let this deficiency completely in contact with the soft tissues, which means that every time that we see that we are going to have very thin crest and we will have a deficiency, we promote this deficiency to be on the palatal side, so that all the time it's in contact with the palatal tissues that are actually with a good keratinized tissue, and this would be okay. Okay, so don't graft. Again, I say that total rehabilitation is completely different than single teeth or rehabilitation or partial cases. Now, when we talk about the type of implants that we use, it can only be performed with the Nobel Biocare implants. No, of course not. It can be when you have a good bone and a good amount of bone with good quality, which means if you have medium or dense bone, actually almost all the implants will function, will act well. If you have the angulation abutments to compensate the angulation of your implants, I do not see a reason for it not to work. Now, the thing is, and where it makes a big difference are in the challenging cases where you have very soft bone or when the bone is very thin. And this is, or when you don't have the bone at all. So this is why special implants with a very thin diameter of the 3.3, long implants like 220, 22, 25, the zygoma implants, these were the reason why they were developed, are exactly for this type of cases that we have been, thank God, facing over the years. Now, I will continue. This is one of the cases that we performed the surgery. The patient still had some teeth, but we decided to go for all-on-4 upper and lower. In the same day, we had the fixed prosthesis, and after more or less 4 to 6 months, this is when we advise the patient to change from the provisional prosthesis to this type of final prosthesis. So I do this type of final prosthesis are performed 4 to 6 months after the surgery. Yes, so Alex, you were talking about possible complications that we might have. Complications that we might have, one of the biggest complications or the most common complications that we have, that are not complications at all is actually when we lose one of the implants. So imagine that you lose one of these implants. If you lose one of these implants, basically the solution is to do another one. As you have seen from our studies, we are talking about 10 years having a success rate of our implants that is not 100%. So we have been following our patients for now. We have patients with more than 20 years of All-on-4 and with implants. So whenever they lose an implant, which is common, as you can see, because we have thousands of patients, we have to redo the implant again. So this is one of the most common complications. So we do it in the same day that we remove the implant. We try to do another one and then connect to the bridge. If it's an all acrylic bridge, it's very easy. If it's already with the titanium bar, it might be more difficult to use the same infrastructure, but it's not impossible. We have a fantastic lab, and sometimes it's possible to still use the same framework. So you can see here the OPG with 10 years of follow-up. Another case of periodontal disease, mobile teeth in the lower jaw, no teeth at all in the upper jaw. So we decided to go for All-on-4 bimaxillar case. So we raised the flap, did the surgery, and placed the teeth in the same day. Again, we placed our final prosthesis after 4 to 6 months after the surgery. Here you can see, and here is our patients. So when we review, imagine that we have this case and we lose one of the implants. So if we lose one of the implants in the front, what do? I can go with the implant more to the left and more to the right. So use another implant position, another bone position to place my implant. If it's an implant that has lost bone like this, I will use another site to place to redo my implant. If my implant suddenly, because of some reason, got encapsulated and came out like this, and has all the 4 walls of the bone, I clean it very well and use in the same position. I go with the 3842 drill, and then using the same position a wider implant like the 5mm RP from Nobel Speedy. This is the one I use in the same position to connect then the implant, and if it has stability, I will reline to the prosthesis. And for the laterals also, so it's the same. If the one in the front fails, it's the same. If the angulated fails, it's the same. I will try, or either I go more tilted, I go more to the back, I go more to the front, go with the wider, or if I do not have any bone at all, then I will have to go for the zygoma. Yes, our prosthesis is always still first molar, which means this is why when it comes out in the first premolar, our bridge will have 2 teeth in cantilever. So this is another case, a case where we do not have any teeth at all. This is the case where the people look at it and they all want to do this case, but when they see the smile of the patient, they said, no, thank you. So actually this is the type of case where you have to reduce a lot of bone because of the smile line, so you do not see the transition zone between the artificial and the natural gingiva of the patient. So we open, raise the flap, reduce the bone, and do upper and lower All-on-4. And at the end, this is how it looks. So this is the smile of our patient. And here is the OPG with 2.5 years of follow-up, here with 9 years of follow-up. Another case, still with several teeth, but with the crossbite, caries on the roots and mobile teeth, so impossible to save. As you can see, no prosthetic height there to place our implants. So upper and lower all on 4, and this is how our patient looks in the end. So 8 years of follow-up with these prostheses. Another case was, this case was performed in 2002, the lower surgery, so we extracted all these teeth. We did lower all on 4. Here you can see a Marlborough Clinic bridge, ceramic in the lower. This is from 2003. This is how it looks in 2003. And here, 8 years of follow-up. By this time we did the upper with zygoma because the patient could not wear anymore this type of solution. And here with 15 years of follow-up with the lower. So when you don't have insufficient torque, yes, you go for delayed loading, which means that you do the best you can in order to place your implants and to have a good primary stability of your implants, okay? So you do the endo preparation, you use longer, wider implants, you try to go bicortical, you do all this. But even in this case that you do not achieve, no problem. Suture everything, and in 4 months you go for the loading of your implants. Now, when you go in 4 months for the loading of your implants, please, please, please always go for an all acrylic bridge first. We, as you're going to see with Philippe, always use the prosthesis as a provisional prosthesis, all acrylic, easy to repair, easy to change as a test drive. This is very important, okay? So the minimum, the maximum length that you need for the tilted implants are basically the maximum length. Well, is the 50 millimeters that you have with the zygoma implants. But for a standard is the 25. This is what we have for a standard all-on-4 case. This is the maximum. The minimum for the angulated, I would say about 10 millimeters. But there are cases, for example, in the mandible, extreme cases where you don't have a lot of bone, but are already used for the angulated one, like 8.5. The minimum would be, I would go for 10. It would make me comfortable to go with the angulated 10 millimeters. And in the front, sometimes I cannot have more than 7. So this is the minimum. The maximum, like I told you, is 25 millimeters because I have this available. And going for zygoma, I go with the 50. So another question from Alex is, he says he does every case guided. What would you say to the lateral mandibular implant? Should I still search for the nerve or just trust the guide with 4 millimeters of space to a mental orifice? Well, I think that actually there is, I think that guided surgery is already an advanced, very advanced surgery, because guided surgery is a surgery that is very dependent on a very good planning, which means that in order to have a good surgical guide, you have to have a very good radiological guide, okay, and so it cannot be unstable. From what we have seen from the studies, we have very good results with, for example, with the Nobel Guide and the all-on-4. But sometimes we know that depends on the case and depends on the planning, depends on the people who manage that. You can have a distortion. So I think that in the future, of course, there is a place for guided surgery, but I think the future will be more the navigated surgery, because with the navigated surgery, you can actually control well where you are drilling in relation, for example, with the nerve. Okay, so that would be my advice to you. Okay, so guided surgery is not at all for beginners. Whenever you are in doubt, you have to be able to raise a flap, to open, to see very well, and to expose the nerve if needed. Okay, so if you have good results in guided, if you can see from before and after that you don't have a big discrepancy, of course, I think that 4 millimeters from the loop of the nerve, not from where the nerve is coming out, from the loop of the nerve, it's more than safe. Okay. So this is one case that was performed in 1998. This is the patient by that day, and she had no teeth in the upper and in the lower jaw, as you can see. These are the type of marks that we use on the nose and on the chin to control the vertical I mentioned during the day. Here you can see we raised the flap. This was 20 years ago, 21, sorry. So we were already raising the flap completely to expose the coming out of the nerve, already reducing the crest here to have a good a wider crest in order to place our implants, already placing our GPS in the middle, our all-on-4 guide, placing all the 4 implants. These are the implants placed tilted in the back with the multi-units connected already to our implants. Doing the impression. By this time we were using the prosthesis to do the impression and then relying on the prosthesis. So many things we changed. We are not using light silicone anymore, because unfortunately the light silicone can get trapped in beneath the suture, and unfortunately we lost some of the implants. We learned with our mistakes, and we lost implants just because of that. So use only putty silicone, don't use the light silicone. Okay, did the impression, and then we send the impression to the lab. We run the stone model. We articulated the prosthesis that actually was also our tray, and we then relined the prosthesis into our abutments with our model in place, and we changed the removable prosthesis to a final fixed all acrylic bridge. And we connected in the day, as you can see here, and this is the OPG and our patients. So this is in 1998. This is the OPG. Unfortunately, by this time, as you can see, we were still doing as many implants as possible in the upper jaw. But of course, they also work. Actually, we lost one of the implants in the upper after, I think it was after 6 years. Here is the OPG with 10 years of follow-up. Here is our lovely patient after 10 years. Here is, as you can see, the final prosthesis with 10 years in the mouth of the patient. Here are the periapical x-rays with 20 years of follow-up. And this is how it looks in the mouth of the patient after 20 years. So actually the patient got older, as you can see, but the teeth remain the same, as you can see here. Good. So now just to finish, and this case was treated with Zagome implants, but this is just for you to have a notion of this type of protocol. This is the case of Barbara, that she lost all their teeth and lost her maxilla due to oral cancer. And she lives in London, although she's Portuguese. And she was, well, many surgeries were performed in order to try to rehabilitate her, to try to give her bone, to try to, well, they did several things, but actually for more than 20 years, She could not use any prosthesis at all, any teeth, any prosthesis at all. So when she came to us, she was sent to us by the BBC channel, and when she came to us, she looked like this. So by this time, we did an OPG, the CT scan. These are the intraoral picture, and she said, Dr. Malo, do you think you can do something for me? And he said yes. And she asked when, and he said tomorrow. So the next day we were in the OR performing this surgery to Barbara. As you can see, she has no maxilla at all. She had no teeth at all, and actually in the same day we got to give her nice teeth back. So we perform All-on-4 in the lower, we perform double or quad zygoma in the upper, and this is how it looked after the surgery with the rehabilitation. The prosthesis that we placed, the provisional all acrylic prosthesis, look like this. These are the coming out of the prosthesis, and this is how she looks already in the same day. Of course, we wanted more. We wanted more lip support. We wanted to do something for the chin, for the nose. So we worked together with the plastic surgeon, try to improve that. And we would also wanted to have a bigger lip support, a better lip support. So every 2 months she would fly into Portugal, and we would add more acrylic to the prosthesis and try to have basically more lip support. So this is how it looked with the final prosthesis, and this is how it looks, the OPG, with the final rehabilitation. This is how Barbara looks now. As you can see, we were able to improve a lot her function, her aesthetics, and basically she got married again. I got to go to her wedding, which is always good. And she had another baby, and she even wrote a book about this. And in the book, she states how important it was for her to have fixed teeth again. And she states that immediately following the prosthesis placement, I was given a green apple to crunch. I thought Dr. Malo was joking with me. I got to give a nice bite, something I haven't done in more than 10 years. And when a mirror was placed in front of me and I saw my smile, I cried like a baby. And it's true, because I was the lucky one to deliver the provisional prosthesis to Barbara. So at the end of the day, it's about Barbara, but it's also, again, about Miguel, about Maria, about Isabel, about Francisco, about all the patients that come every day to my office, but also to yours, and that we are basically able to change to a better quality our patient's life. So thank you very much. Now we have still some minutes for some discussion, for some question and answer. Meanwhile, you also have here my email, my links in the social media, so you are always more than welcome to write me, to send me an email. Feel free to add me on your social networking, and I will try to go through some of the questions that maybe I did not answer. But if you have more questions to write, please write now. So, okay, if we miss the position of an abutment, and if we want to change the abutment position, yes. So what do we do? Sometimes it's difficult to know exactly that. Of course, we would love to place the abutments in the same position and the final abutments that would place in the surgery, that they would go forever. But sometimes, yes, sometimes the abutment may come out too much vestibular, and we might need to change that for an angulated abutment, or it comes out too much palatal and the prosthesis get very thick. So sometimes we have to change the abutments. When do we do that? When we go then for the final prosthesis. So when we go for the final prosthesis, we are able to change the abutment in order to improve the aesthetics, the function, the vertical dimension, the everything. So when do we remove the temporary prosthesis after the surgery? So immediately after 10 days, between 10 days, 15 days, between 1 to 2 weeks, the patient comes to remove the suture. This is the time when we unscrew the prosthesis and we remove the suture and clean everything. Miguel is going to talk about that in the maintenance protocol in his session, and you are going to see how a protocol is, but we will always unscrew the prosthesis in these maintenance appointments, and every time the patient has a problem, if the bridge breaks or something, we'll always unscrew. This is why it is so important to go to abutment level. So what do we profit if we entered inside the nasal cavity with the implant? Okay, so I do not want my implant to be inside the nasal cavity. What I profit is from the cortical that I have. This is the nasal cavity, and I have this cortical. If I have soft bone here, if I'm able to drill here and engage my implant in this cortical, I will benefit because it will enhance the primary stability of my implant. I do not want my implant like this because this is in air. I want my implant in bone. So I just need to engage the tip in order to enhance its primary stability, because the corticals are always denser, are always better bone to give better primary stability to our implants. No, so Alex is saying, should we wait 7 to 10 days and do the impression and then the prosthesis? No, I would advise to load immediately, load in the same day. The patient doesn't need to be 10 days without teeth. It's for the patient, psychologically, it's very important that they will leave the same day with the teeth. I think it's very important. So please try to prepare a prosthesis before, and in the same day you realign the prosthesis to the implants. So you can actually have, like, it would be an immediate removable denture. After placing the implants, after suture, after everything, you connect the copings, okay? You connect the cylinders of the bridge, you open the holes into the removable prosthesis, and then you realign the removable prosthesis to your cylinders, okay? Philippe will talk about that, on how to do the immediate bridge, how to do it if you have a lab, how to do it if you don't have a lab, and to do it chair side, okay, so that you are able in the same day to deliver the prosthesis to your patient. That would be that is the protocol, that is what we want to achieve. More questions. About All-on-2, I saw a new trend. I don't know about All-on-2, not All-on-6, not All-on-8. All-on-4 is registered marked, so the other ones are not. If you're talking about having a fixed bridge over 2 implants, it might work. Especially if you have very old lady with very thin masseters and she does not chew a lot, it maybe work. Maybe one implant itself might work, I don't know. But a protocol is something that you can that I can easily say that suits everybody. Okay, so the All-on-4 suits everybody with all types of bone, with all types of bone condition in terms of height, width, and in terms of density. So I do not have any experience with with the only 2 implants and a fixed prosthesis over this. I do not think it's okay because, for example, I had already had cases that lost 2 implants, and I was not able to replace the 2 or 3 implants immediately, so it stayed on the 2 posterior. And what happens is that you'll start to have unscrewing of the screws, prosthetic screws. You'll start to have big cantilever in the front, so you'll start having biomechanic, especially biomechanic complications. You have breaking of the prosthesis, unscrewing of the prosthetic screws, and screwing of the abutments. So I do not advise you to go with only 2 implants. So I would advise you to go with 4 implants doing the All-on-4 protocol. In thin maxillary cases, should we try to engraft first? 2 millimeters with 5 millimeters of height. Well, you have to show me these cases, because I don't see how grafting would be possible in these cases, where you also have a very thin layer of the cortical. To remove it from the hip and to do a reconstruction, forget it. If you only have 5, I'm not mistaken if you say 2 millimeters with 5 millimeters high. I do not understand well your question, because if you have a very thin 5 millimeters high mandible, usually it's not 2 millimeters of thin, it's usually a little bit bigger. If you try to drill there, you will break the mandible. So it depends on case to case. You have to evaluate very well your case first. If you have and if you can, use a 3D software where you are able to plan your case before. Like, for example, I use the Nobel Clinician. Now it's called the DTX Studio. So it's very good for us to actually to do the planning and the diagnosis, and many times to show to the patient. It's very important. So this is my biggest advice: to have a very proper diagnosis, to plan very well, and then to be trained. This type of training, this type of online training, is a training that to open your eyes, so to say, to this new possibility of rehabilitation of dental patients. But I know it looks easy, but you should, and you have to have the proper training in order to be able to perform this protocol. Okay, good. So I do not know how we are now, if we still have time or not. I'm going to ask here. Do you still hear me? Okay, so to check the loop, you just need to insert the probe. Yes. So to check the loop, what you do, you raise a full thickness flap, you go with the periodontal probe, and you go always in contact with the buccal wall of your bone. Okay? Always in contact with the buccal wall. This is very important. Then you see when you hit this wall here. So I would advise you to now write down all the questions that you still might have. In the beginning of the next session, next week, you can write me more questions and we can come to these questions again. And I will be more than glad to answer because next week we still have, you still have 2 more hours with me. So take advantage of that, and it was lovely to be with you this afternoon. So hope to see you and hope to hear from you next week. Thank you very much.